Assalamu alaikum. The article of this week is titled Pulpal Deterioration Following Restorative Procedures, a Case-Controlled Study. It was published in the Journal of Endodontics in 2025 by a Canadian group. Although there is multiple studies have explored the association between restorative procedures, pulpal deterioration, and the subsequent need for root canal treatment, there is a gap remains in defining the specific risk period following the most recent restoration preceding pulpal deterioration. And to date, there is only two studies have directly examined this interval. However, their findings are inconsistent. So the aim of this study is to address the discrepancy in reported critical time lapse by providing a comprehensive evaluation of the temporal relationship between terminal restorations, the development of pulpal deterioration, and associated risk factors. Moving on to the materials and methods. The study was conducted at the University of Toronto using electronic dental records from 1999 to 2023. For their inclusion criteria, permanent teeth that received a definitive restorative procedure performed at the university, followed by subsequent non-surgical endodontic treatment, which are pulpotomy, pulpectomy, or non-surgical root canal treatment therapy. For their exclusion, primary teeth, prior endodontic therapy, treatments done outside the institution, or IRM as the final restoration. So a total of 1,360 teeth were identified as cases and matched with 1,360 control teeth, and which had similar characteristics such as age, tooth type, and the number of prior restorations. But it didn't undergo endodontic therapy and had at least 2 years of follow-up. Then the data extracted included patients' demographics, restorative material and type, number of restored surfaces, use of pens, stepwise restorations, crown lengthening, and presence of pulp exposure. The primary outcome measured was the time lapse to pulpal deterioration, defined as the interval between the placement of the terminal restoration and the subsequent initiation of non-surgical endodontic treatment. The statistical analyses were performed and variables significantly associated with the deterioration were identified. For the results, the median time to pulpal deterioration following terminal restoration was 14.3 months. Crowns and bridges demonstrated the longest interval before pulpal deterioration by 28 months, followed by amalgam restorations by 17.4 months. Composite resin and glass ionomer restorations exhibited shorter intervals, averaging 12.9 months and 12.4 months respectively. Teeth restored with more than two surfaces showed a shorter median time to pulpal deterioration compared with those with two or fewer surfaces. Also, the posterior teeth presented a slightly longer median interval than anterior teeth. For the pulp exposure, it was associated with a markedly shorter survival time, which was 6 months compared with 15 months in non-exposed teeth. So lastly, in the multivariable Cox regression analysis, both restorative material and number of surfaces were significantly associated with pulpal deterioration, where the teeth restored with glass ionomer were about 1.6 times more likely to develop the problems compared with those restored with amalgam. And also the teeth with large restoration were about 1.5 times more likely to have pulp deterioration than the smaller restorations. In conclusion, pulpal deterioration may occur after a median time lapse of 14.3 months following terminal restoration placement. Crowns and bridges and amalgam restorations were associated with a slower progression of pulpal deterioration, whereas composite resin, glass ionomer, multi-surface restorations, and pulp exposure were linked to an increased likelihood or earlier onset of pulpal deterioration. So, in my opinion, the paper has many limitations, such as the retrospective design, and also using the start of endodontic treatment as a surrogate for onset of pulpal disease, which underestimates the true onset of pulpal deterioration. Also, the unmeasured confounders, such as remaining dentin thickness, cracks, the presence of recurrent caries, which were not recorded. The other thing is that they were working on a single academic settings, which may limit the generalizability. The last thing is that because the study covered a long period, so cases and controls weren't matched by treatment year, which may have some differences of materials and techniques over time, which could have influenced the results.